welcome to all of our guests here today to speak on your testimony within item number 4. Jane will add some context for members around why they're here shortly. Moving on to apologies for absence. Do we have any apologies for absence?
Yeah, I received apologies from Councillors John Fulcar and Councillor Fengeli, so Councillor Keeler is a substitute.
Thank you. Second item, members' declarations of interest. Do we have any declarations of interest around the topics on item 4 and item 5 from members? No? Thank you. Now, minutes of the meeting held on the 9th of January 2024. Do we adopt those minutes? Any inaccuracies? Yes, Councillor Brown.
Yes.
Oh, yes. Oh, right. Okay. So we vote for it. Yes. Brilliant. Thank you. Everyone in favour? Superb. Thank you very much. Okay, item number 4, substance misuse. I'm going to give it to Helen Dennis to move this item. Oh, but Jane first to give a briefing. Thank you, Jane. Sorry.
Thank you very much, Chair, and thank you everybody for bringing this really important issue to scrutiny this evening. We were asked to bring this following a meeting in January, and then the meeting after that we talked about the rough sleeper drug and alcohol offer that we've been working with our colleagues on. And it was at that meeting that it was raised that it would be really good to have a wider session about what are we offering in our local communities for people who want to go into that road to recovery from alcohol and or drug issues. The first thing I would say is that we are doing a slightly different approach this evening, as colleagues may have noticed, in that we have a number of service users but also services with us here this evening who wanted to be part of the discussion and to share their own experiences and bring to life some of the figures and some of the information that will be in the paper that has been written by Helen as part of this process. We would like to try and look at doing this more with public health services, and I thank Councillor Lewal for giving us the opportunity to do something a little bit different this evening. We've also asked Councillor Lewal to consider bringing a range of public health services to this committee going forward because we really value the opportunity for scrutiny. And so we look forward to being here with lots of public health services going forward. And with that, Chair, I will pass over to Helen with your permission.
Absolutely. Thank you, Helen.
Thanks, Jane. So in terms of the format of how we're going to talk to you, I'm going to do a very brief overview of the context, some of what we understand about local need, and start to bring over the themes that are important to people who use our services. And then what I'll pass to is each of the services in turn to say a bit about a range of issues that are important to them. So in terms of the initial context, and you'll have seen this from your paper, commissioning drug and alcohol substance misuse services are a mandation of the public health grant. So this is something that we have to do, although of course it's something we would have chosen to do anyway. And in terms of the national visibility on this as an agenda, Dame Carol Black talked about the needs of people with substance misuse issues from harm to hope. And that led to the government thinking about what are the extra things that we need to do. First, in terms of investment, I'm thinking about what we need in substance misuse services, trying to get more people into treatment, ensuring that the pathway from prison and out into services works well, thinking about how we learn about sustained recovery, and also thinking about how we reduce deaths from substance misuse. And when I'm talking about substance misuse, I'm always talking about drugs and alcohol, because we know when we look at a population level, what causes the greatest harm, then that it absolutely is alcohol. We have a combating drugs partnership with Jane chairs, and that sets our strategic direction across the range of issues that I've talked to you about. We know that people with substance misuse issues face significant health inequalities. So not just in terms of their health itself, which can have a range of long-term conditions that are associated with alcohol and substances, but also in the way that they're able to access other services, whether those services are health services or when we think about housing, employment, and a range of other issues. And in terms of just really highlighting the sort of scale of that, between August 21 and July 22, there were 5,412 admissions in 3,455 residents of Northamptonshire that were coded as related to drugs or alcohol. And when I say coded, that underpins every admission to hospital, tells us a bit about what it's about. Many of those relate to physical health issues. And whilst that seems a really high number, and of course it's something we'd seek to reduce, it is broadly similar to the average that we see across England, we also know that people with substance misuse issues are much more likely to attend emergency departments, a staggering 16,846 in that same time period. And we know, of course, that that's a cost to the public purse, but also has an impact on the individuals and families and communities. Often indicates that we're not meeting needs as much as we could. And then in terms of deaths from substance misuse, 134 deaths from substance misuse between January 19 and June 22. And we have a formal process by which we explore drug-related deaths. Alcohol-related deaths a bit harder to estimate. We get into some sort of statistical of what's directly attributable. But we know that's a much higher number. The last process I'd like to highlight to you is our local drug information service. And what that does is provide an early warning system where there's either an adulterated drug or there is a substance that's had resulted in an overdose, and perhaps presenting in a way we might not normally expect. And we have a thorough process by which we explore that. So this is the bit where we start passing to people in turn. I'm just checking that I know where Ali is. So I'm passing to Ali from CGL, and then to Adam, who will share a bit about his experiences.
Thanks, Helen. Is that working, isn't it? So I'm Ali. I'm the services manager for a organisation called Substance Dissolution, or S2S as we're commonly known. We deliver the drug and alcohol treatment services for adults across Northamptonshire. That's delivered by a charity called Change, Grow, Live, CGL. So we have a bit of in the local communities, we get referred to as S2S, Substance Dissolution, Change, Grow, Live, or CGL. That's all us. But generally our service users would know us as S2S. We deliver a range of support for people with substance misuse and alcohol issues, including prescribing treatment. So what people would often talk about are things like methadone prescriptions, but also things like access to rehabilitation, access to detox, and a range of other one-to-one support options, which could be things like group work as well. We are based, as I said, across the county, so we've actually got buildings, locations in Northampton, Corby, Wellingborough, Kettering, but we also have some outreach services in Daventry, Rushden and Brackley as well. And that's one of the things that we're trying to work on, is cover that rural geography across the county. Within the service, we employ a real range of roles, so doctors, nurses, recovery workers, and recovery champions is a really key role that we employ, which brings people with lived experience into the service to work with and support people. And I guess on that note, that might lead us nicely on to the next person, but that's in a nutshell.
Thank you. So, yeah, I'm Adam. I'm a recovery champion based at Corby S2S. I suppose, obviously, we're a substance misuse service, so we see a lot of alcoholics and drug addicts enter our service, and I think the main thing to say is you've got to want recovery to be able to get recovery. But even the ones that would come through our door that maybe don't want recovery, we're able to do that harm minimisation, which is massive and could potentially save their life until one day they are ready. I'm living proof that recovery is possible. I was a heroin and crack addict myself. I've been in and out of the prison system. I was in the care sector as a child. So I'm living proof that it's possible. And I think one good thing about us at the moment, in many years it weren't like this as a services, but like if someone wants treatment, like today we had someone that come in today off the street just to walk through the door. We've managed to get them fully assessed, and they're going to be starting treatment tomorrow morning. So we can work very quickly for the ones that want it. We try and get out there and branch out and offer as much support as we can. We do home visits if they're not able to come into our service. And we just try and work with best suit their recovery.
Hello everybody, Zoe Churchwood. I'm the service manager of Engage Young People's team, which is the service, a county-wide service for young people aged 10 to 18 years of age. We work from right through from early intervention, delivering education for year 6, year 7 transitions, right through to education for targeted groups, to delivering harm minimisation and one-to-one structured treatment for young people across the county. We have an admin hub in Northampton, but we see young people in places that they wish to be seen, which can be anywhere, quite literally anywhere, but generally education environments, care homes, community buildings, youth groups, and we really try to make sure that we get as much education and early intervention out to those young people, where prevention is obviously key, but we are seeing and do work with an increasing complexity of young people needing structured treatment and unfortunately sometimes clinical intervention. I don't know if you want to say anything.
Yeah, just to say, obviously the service encompasses, obviously we cover the whole of Northamptonshire. Our staff are locality based, so that they get to know that locality and all the other support services that are around the young people. We work quite holistically looking at the other factors that might impact on a young person, so it focuses on the substance misuse, but we also look at education, meaningful use of time, mental health, you know, those other factors that are there to support a young person with their recovery. One of the, I guess, multiple aspects of the service is we look at prevention, early intervention, but as Zoe mentioned, that structured, targeted intervention for the kind of more complex, higher risk group young people. And I think one of the key strands that runs through the whole of our service is our youth participation. So we have an Evolve YP steering group that is about us actually hearing and grasping the voices of young people who use our services and kind of tailoring our services based off that. So it's always getting their views and opinions. And also we're going to be running a youth mentoring program where, again, young people who have been through the system and receive support can support other young people. And I think that's key, is people who have experienced these things is giving back into services. So that is a key function of some of the work that we do and working multi-agency to bespokely support additional elements of work as well, like bespoke mental health and trauma-informed work that sits alongside the substance misuse intervention. I don't know if you want to...
I'm not going to read it out because also I've left my glasses in the car. So, but we were unable to bring any young people with us this evening for a couple of reasons. But what they did ask is that we share, we've got a nice glossy surface booklet that they've just produced, and there are several testimonials and experiences of their journey within this, and this is sort of our most up-to-date group of young people that work with us on our youth steering group, and so they have asked, I've got them with me, that we share them with you that way.
Hi, I'm Steve and I'm from Bridge. So Bridge is the substance misuse recovery service working with adults. So we've got 3 sites, one in Northampton, and we've got 2 in the north, which are Wellingborough, and then we've got one just across the road in Corby, in Grosvenor House. So the idea of Bridge is to look at all the reasons as why somebody might be using and try and tackle those. So common themes, you know, coming from your last meeting, homelessness, housing is obviously a big issue. So we have a number of different staff members who can deal with those reasons. So we do have housing support workers, recovery workers, as the others do. We might look at your physical health as well. So we have, in Northampton, we actually have a gym ourselves. It'd be lovely if we could have one over in the north as well, but at the moment we can't do that. But we look at the physical side. So you're looking at walking groups, gym, football groups, those sort of things. You're looking at the 5 ways to well-being sort of side of doing things as well. So in terms of what we do, we have a timetable of activities. You can become a member, as these two guys are. So we call service users members because you become part of a club, and it's more informal and it seems to work well. But you have a timetable of activities and you can choose which of those actually benefit you. So it's all person-centred. So it's not you don't need to come to us 5 days a week. We're open 10 till 2 in Wellingborough and Corby. So you don't need to come 5 days a week, but you can use the bits that work. So what we want to do is work, as we do with the guys over there, alongside treatment. So you go in there, you're getting that support need. And then the recovery part, you're meeting other people in recovery. So one of the things that we know about substance use is that it can be one or two things. Either you're using with people, which is obviously not a good thing, or you're using on your own, which means you're isolated, and that's also not a good thing. So what we're trying to do is get people around positive peers. So peers that can then actually support you in your recovery, that actually want you to do well, rather than keep pulling you back into addiction. As I say, the other side of isolation is one that we see is a massive reason of why people use, but also a good reason of why Bridge, I think, actually works, is because then people are coming out, they're meeting other people. The impact of that is huge. So as I say, I've brought along 2 guys with me today who use our service, who's going to just talk a little bit about their own recovery and what they've got from Bridge. So we've got David here and Rob. Rob, actually, and he doesn't mind me saying this, when Rob came to us, Rob was homeless, and later on in his recovery, we were able to put him into something called phase housing. So phase housing is supported housing for people with a substance misuse problem. The difference between our supported housing and the other usual model is that these are self-contained flats. So we have 16 one-bed flats and 4 two-bed houses. So they're not traditional in the HMO sort of setup. They're also 2-year tenancies, so it actually gives people the opportunity to sort of develop and build on their recovery, moving towards independent living. We want people to work towards jobs, training, education, volunteering. So we want people to progress. It's not just about, and this is the whole of Bridge, it's not just about stopping your substance, it's about where you can move on with your life. So, as I say, working with these guys, I think we do all right at times. So, yeah, so I'm going to introduce you to David and then Rob.
Hello, I'm David from Bridge, and I'd just like to say if it wasn't for Bridge, I wouldn't be here. I've been clean for over 13 years now. People's going to think, like, 13 years, you ain't got a problem, but things still happen in them at time. Like, I'll give you an example. I lost my sister 2 years ago, and my partner had a baby to someone else. And if it wasn't for Bridge and the members and the staff, I wouldn't be here today. I wouldn't be here today, truthfully. But I'm a bit nervous about this, to tell the truth, but I've got so much to owe to Bridge. I volunteer now and then, and it gives me a routine. If I didn't have Bridge, I wouldn't know what to do. And I'll leave it there. Thank you.
Hi, my name is Robert. I use Bridge, and like Adam, I've been a heroin addict since mid-80s. I tried to get clean before, but didn't work. I did have a flat in Northampton, but the flat was being cuckooed, and I had to get out of there for my own safety, so like, I ended up making myself homeless again. And I became a member of Bridge, and as Steve mentioned, phase, I got one of them phase houses, And if it wasn't for fees, I'd probably still be homeless, maybe even still using, if I was still alive. Because when I come into recovery, like I was down to 7.5 stone, which I'm not much heavier at the moment, but yeah, Bridge has been a lifesaver, you know. And yeah, phase housing, that really helped me. Now I've got my own place, and I've been 7 years clean. And don't know what else to say. Thanks very much.
Trina, over to you.
Thank you. My name's Trina Breed and I'm the Operational Manager for Family Support Link. So behind most people with addiction, there's a family. So we're a very small charity with only 10 employees in total, which covers the whole of Northamptonshire, and we work with individuals from the age of 5 upwards. So the aim is around early intervention. We offer physical and emotional support to family members and recognise the impact that living with a loved one with a drug or alcohol problem has. Now, this can range from numerous things. I can give you an example. There was a lady who was in her 70s and her adult son was using heroin, and she felt that it was more acceptable for her to go to the dealer and purchase heroin on his behalf because she thought she could control it. The next thing she knew, the dealers were at her house and subsequently demanding money with menaces, and she ended up paying them £40,000 because she didn't want her son to be hurt. A lot of our family members won't speak to others because they're frightened of the stigma that sits behind that. So it can feel very, very lonely. So we offer one-to-one support and group work. We have a group online, and what we have is a social club, which is a little bit more informal, that moves around the county to give people that option to have people to talk to. Also, with our youth engagement, we offer activities throughout the Easter holidays to allow children to be kids and to give them the opportunity to have some fun. Because we find with some of the children, they're either looking after their parents, who may be the drug or alcohol user, or potentially they may be looking after younger siblings. As a result of that, obviously that does give significant complexities and challenges because of the barriers that our families are faced with, and they often feel that they are often forgotten. So I really thank you for the opportunity for me to share a little bit of their voice today. Unfortunately, one of our clients couldn't come along, so she has given me permission to share a case study. I'm only going to give you some edited highlights from it because it is quite, I'll be honest, it is quite lengthy because it was quite an involved story. So I contacted Family Support Link 10 years ago when we were having problems with our daughter. Years earlier, she had some difficulties as a teenager with alcohol, which her teachers highlighted to us, which she constantly denied. We knew she might be still having problems when she went to university, but things seemed to improve during the first few years, but she became more and more unsettled. Eventually, she was a physical wreck and asked to move back home. At this time, she had a stable boyfriend from her university, and it wasn't until later that we found out that not only were they drinking, but she was also using heroin. Being away at university had escalated her need to use. Subsequently, sadly, her boyfriend was killed in a car accident. This escalated the situation for my daughter, which she clearly was struggling with by having lost a loved one very, very tragically. And she started getting into trouble again, which involved the police. She was taken to hospital numerous times. She was even sectioned. But nothing anyone seemed to say or do seemed to get through to her. We just didn't know where to go to help her, and nothing seemed to work, as no one seemed to know what to do. Unfortunately, she met somebody else in hospital who was also having problems, and this situation escalated further. I went to visit her while she was living with this gentleman, and unfortunately, it resulted in a very abusive and aggressive altercation. And one thing that I do regret to this day is that as a result of it spiralling out of control, it did go to court, and I wish I hadn't done that. She carried on drinking and stopped several times, and I was really struggling to cope, feeling completely helpless, and her probation officer mentioned Family Support Link. It was only later that I realised that I had someone to speak to, that wasn't going to judge me, that was going to allow me to listen and tell my story. I found that bottling things up hadn't been helpful for me. And I also went along to the group and realised that I wasn't on my own. And as a mother in the county, I suddenly realised that sadly there was a lot of other people in very, very similar situations. Nobody's situation is identical, but there is commonalities. And as a result of that, you form a bond and receive peer support. Eventually, my daughter agreed to go to S2S, and this really helped. She went into rehab for a number of months, out of county, and at that time we were still engaging with her. We still wanted to have that relationship with her. We didn't want to cut all ties. She was still my daughter. I'm pleased to say that after a very long struggle, my daughter is now in recovery. She now works for a similar service to S2S in the south. She has stayed out of county. We have a good relationship. She recognises her limitations. She knows that she's always in recovery. There has been instances where she's been asked to go to conferences where alcohol has been readily available, but she's chosen to go to bed early and not get involved. But by contacting family support, it allowed me to have the support that I needed, allowed me to talk to somebody. I couldn't have done it because I couldn't even tell my parents what was going on at the time because they would have been absolutely devastated. Even though problems were still ongoing, I felt that I could still speak to Family Support Link. So I started volunteering, and I help at hosting the group. I just think it's a shame that the population today are denied some of the real information that is out there because people are too scared to look or too frightened to even ask for help. My daughter works for the organisation and often talks to family members that are in similar situations to where I was. I think it's uncommon that it's proper help for families, and I think it's really important that there is still that link and that support for families available. Thank you for your time.
Thank you, Chair.
Wow, thank you very much, and particularly that was a very potent and pertinent case study that I think all members, it's good that all members can hear that. And thank you to all of the eloquent speakers as well for sharing your experiences and the service providers for sharing what you do to support people involved with substance misuse. I'm going to open out to questions to members. I am going to start off with a question, if that's okay to the service providers. Thank you. One of the questions that I had, and I'm looking at other members as well, do you work with, this is to Ali from S2S CGL, do you work with organisations such as Teen Challenge? Is my first question. Second, what are your outcomes, successes within what you do? I know you mentioned a few, and are there more alcohol than drugs? What's the percentage difference? Thank you.
Can you just repeat the first bit, first
question?
question?
Do you work with an organisation called Teen Challenge? I know they work with rough sleepers.
No, I'm not aware of them, so the answer to that is no, but we're always open to working with organisations if they contact us, for sure. You were talking about outcomes as well, weren't you?
So around your outcomes and successes, what's your...
So we're measured on our outcomes, so that obviously goes through the work that we do with the local authority and an organisation called OHID, which I'm really hoping Helene might remember
Office for Health Improvement and Disparities.
It changed not that long ago, didn't it? And the new one hasn't sunk in yet. So we get measured on outcomes around successful completion. So every month we will process through a database system the number of people that have successfully recovered from substances and alcohol. So in terms of substances, that's measured around opiates, so heroin, what we would call non-opiates, which is basically everything else. So that could be cocaine, crack, cannabis, and alcohol, obviously. So we get measured on those every month, and we have like performance indicators around where we should be. So we get compared with other services across the country in terms of demographic, size, that kind of thing, and see where we should be, what the recovery rates are. We're also measured around numbers in treatment. So Helen talked about the From Harm to Hope, the Dame Carol Black Drudge Strategy. So in there it talks about the things that we need to be doing, so preventing harm, so giving out things like naloxone, which can help people if they're in overdose from opiates. Things like, again, drug-related death, reducing those numbers, and numbers into treatment. So we're measured against the number of people that engage with our service, stay with our service for a meaningful period, and continue their recovery journey. So we're measured in all sorts of different ways, but essentially around that. We also do criminal justice work, so that's with probation. So we do DRRs and ATRs, which is drug or alcohol rehabilitation requirements. So again, that work is looked at by how many people go through the court system, are given those requirements, and how many people successfully recover. And by that we mean free of drugs and alcohol for a meaningful period of time. There was another part as well.
Yes, it's just about, do you get more alcohol than drugs? Just a...
Yeah, I mean, it's an interesting question because we are a prescribing service. A lot of people with a heroin addiction will come to us looking for a prescription for that, so methadone, things like that. So we tend to have more of that in service, but alcohol is very prevalent as well. Often we might find that people who are using alcohol, it can be a more difficult thing for people to acknowledge that there's an issue with, so it's very obvious if someone's using heroin and that's an illicit substance. Alcohol numbers are gradually increasing, and the work that we're doing is focusing around primary care, so engaging with GPs and things as well. And we will assess people around their alcohol use because that can be quite a broad spectrum, but predominantly because we're a prescribing service, the majority of the people we work with at the moment and historically is normally heroin users, but there is still quite a lot of alcohol people on the case.
That's fantastic, Ali, thank you. And my final question actually is for both Engage and S2S. What's your biggest challenge with engagement across the board? What's your biggest challenge? What's
Adam, I think you want to...
So I can answer for S2S. So partly what Ali was saying as well. So at the moment, alcohol. So also we deal with like prison release and criminal justice, but we also deal with any hospital discharges. So we have a nurse that's inside the hospital. So anyone that comes in with any alcohol-related admission or drug, they automatically get referred to us, and we pick them up on discharge. And we try and get them obviously to engage with us if they don't want our help. We're a voluntary service. We're not mandatory, so we're a voluntary service, but we try and obviously limit them. Offer harm reduction advice, and the ones that we find, I had a good example is there was someone that they refused our support 3 times. I've tried calling them over the last 3 months. The 4th time they've accepted, and now they're in structured treatment with us and actually 8 weeks sober. So like, we just got. I think the good thing about us is we don't give up. Like, just because someone doesn't want it today, tomorrow, next week, next month, like, we're going to keep trying every time we get that chance.
It takes multiple treatment episodes for some people, and I guess just answering that in a slightly different way, one of the things we're really trying to focus on, and again working with public health colleagues, is around primary care. So what we're trying to do is increase referrals from GPs to our surgeries. So often what can happen is signposting, which some people work well with signposting, but others need, more of a formal referral that we can pick up. So we're really trying to work with some of the GP surgeries to make that a really easy process for them, and to make sure that we can increase that, because in terms of our numbers in treatment, I think we're working on the idea that actually there's probably still quite a few people that are sat in within that primary care GP setting that we can try and engage with.
Yeah, that's superb, thank you. So, yeah. And engage.
I was listening to that. It's really difficult. I think many of our young people have experienced trauma, complex trauma. An increased number of them are also open within the safeguarding pathways, often not just for, well, trying to think, a lot of it neglect actually, and then we have the safeguarding around, trying to safeguard around county lines currently. Which one is the biggest, or which one the numbers are, is actually really difficult, because they come hand in hand. Most of those are simultaneous together, and cause, you know, real difficulties for children and young people, and we are talking children who obviously come from those difficult backgrounds.
Yeah, no, thank you very much. Graham.
Thank you, Chairman. Well, first of all, I'd like to congratulate all the people who've come and spoken on just doing that, coming and speaking, and on what you've made of yourselves and in what are obviously very trying circumstances. So congratulations. I've got a number of questions and points which may relate to different services, so you'll need to pick up which one, who should best answer. We've got obviously the paper, and we've heard about a number of services and a number of schemes that there are for looking at these issues, the recoveries and the pathways, and how it's a long-term problem. But there's a number of points. There are several services here, and there are others that obviously we haven't touched on, but I just want to make sure that there's no duplication of services and no confusion between service users where to go, so that obviously it sounds like you do work together, but that was it. I was looking at the Dame Carol Black report response from the government with these 3 strategic things, and the first one was to break drug supply chain. So that's obviously with county lines we were talking about. So that's a police matter. So I haven't heard any mention of their involvement and how they fit into all this. And one of the most important things, of course, is prevention. I mean, if we can prevent it, that's fine. And I noticed that there's something like £2.25 million for these services this year, and I just wondered how much is allocated for prevention, particularly as one of the other 3 strategic priorities was to achieve a generational shift in demand. Well, obviously that's trying to get it. That is prevention. We've just heard about working with people discharged from hospital, but do you get, and also prison, do you get the chance now to go into places like Five Wells, because the people, the people who are resident, they call them these days, obviously that they can't, whilst they're there, it's probably the best time to get hold. And the last one, in paragraph 4.10, there's a note about underrepresentation from various ethnic minorities, and it gives a couple of potential reasons. But I just wonder if one of the reasons is, in fact, that it's not in their ethos, and it's just a simple fact they don't get involved as much, and therefore they're not appearing, rather than not accessing services. It may just be that they're, it's not the way they go about things, particularly as their family ties in some communities are quite strong. I'll leave it at that.
Okay, so I'll start at the top. In terms of the question around duplication, no, we don't believe that we have a duplication of service. What we do believe is that different things suit different people, and some people will use more than one service, and I think this is what some of the service users have talked to you about, that you might be having your treatment option through S2S, through CGL, you might access recovery through Bridge. And when I came out to visit Wellingborough last week, there was somebody who I'd met at CGL that there'll be different offers. No, we don't think there is. But we always seek to understand the population to make sure that isn't what we're doing. In terms of the police involvement, because this is health, and trying to make the paper of a manageable length for you all to want to read it, I like to think it was a manageable length. I've not really mentioned the police involvement part of it at all. So the Combating Drugs Partnership, the police are absolutely an active member of that, and the subgroup that they lead is the one around, interrupting the supply. So some of that, it's around county lines, it's around seizures, but they also have a really crucial part to play around drug-related deaths. So often they might be the first person, first agency that's on the scene. But also in terms of when I talk to you about drug-related overdoses, so that if the police are the first on the scene, they might be the person who is able to administer, we mentioned naloxone to you, so that rescue medication. And we were delighted that the police are going to trial that. Now, at the moment, they've said they're going to trial it in Northampton with a small team, but as you'd be clear, I'm very keen that we also try it in some of our hotspot areas where we know we're seeing more drug-related overdoses. But we are absolutely working with a place at chap called Lee. Never very good at remembering whether he's a superintendent. I'm not good with titles, but anyway, yeah, very positive relationships. The way the budget works, we can't easily say X proportion is for prevention and X proportion is for treatment, because many services have different elements to them. So when Zoe and Emma talked to you about some of their work with young people, some of that is thinking about how do we, what we'd call in public health primary prevention, how do we have conversations before anybody thinks about using drugs and alcohol. We also think about that in I always gesticulate, microphone's gone. In terms of our broader reach, so how do we have some of that communication across the population as a whole? I do think it's an area where we'd like to do more. You'll know from other work that relationships with schools have changed with academisation. So as authorities, we don't step in and say, you must do this, you must do that. But with mandatory PSHE, we do have an opportunity to say, what are those conversations like, alongside talking to young people about other sorts of risk, because often risk doesn't occur in isolation. I'm going to take underrepresentation next, I think, and then pass back to you, Ali, for prisons, if that's okay. You make a really valid point where we know that in some faiths and some cultures, alcohol in particular, but also substance misuse is not part of somebody's faith. That doesn't mean that alcohol or drug misuse doesn't happen in those communities. What it might mean is that the stigma is much greater. It's going to be much harder for people to seek treatment. They may be more secretive in terms of what's impacting on them. And they might not feel that the service will understand them. So when we're trying to understand who comes into treatment service, and Ali and I had a meeting earlier today about understanding, we can't easily say, in an Asian Hindu society, this is the proportion we see. What would we see in an African Caribbean community? Because we don't have the work that tells us that. What we need to do is make sure that if somebody comes to a service, they think they'll be understood, and they see somebody that they think gets them and understands them. So it's of your questions, it's probably the most complex one, I think, and it's the one that we're really working alongside thinking about, do we see underrepresentation of people who identify as LGBTQ+? Do we see an underrepresentation of women, which is another one of the things we think we do see? So I'm going to pass over to Ali in terms of that specific question around prisons.
Thanks, Helen. And you're absolutely right. In prisons is the best time to engage with somebody who's in that criminal justice cycle. So HMP Five Wells, yes, we've got a good relationship with them. We go in there regularly. Unfortunately, they don't have that many releases from there because of the kind of prison they are. Majority of the people from this county, adults who are in the prison system, are in HMP Peterborough. There are other prisons as well, but predominantly it's HMP Peterborough. That has been quite a challenge for us. So under the drug strategy, continuity of care is one of our targets. We've always sat in a pretty good range for that. But lately it's been a real challenge to even get into HMP Peterborough. So we did have a visit from Dame Carol Black in January it was, and interestingly she raised prisons. We did raise it with her as well. Adam's laughing because he was in the room too, and she told us how difficult HMP Peterborough was, and they don't want to let her in there either. So it's very difficult. We have attended a conference there, and yeah, the aim of the work that we want to do, and we've staff ready and waiting and keen to do it, is to be able to go into the prison, work with people in the prisons, pick up that work in the community and just create that linkage. You know, back in the day, that was the kind of work that I did frontline, and if you pick someone up from a prison gate and help them and support them, they've got a much better chance. So that is, it's a challenge that we're working on around HMP Peterborough at the moment. We are persistent in that, but yes, it's an ongoing. I don't know if there's anything you want to add to that. Oh, Adam?
Yeah. So I just want to add that prison is definitely a good focus, because even though people might be addicted and they go in and out of prison, when they're in prison, even though there's a lot of drugs in prison, they're a lot more expensive, so it's harder. So normally they get a bit more clarity. And I was actually picked up by CGL in 2018 and sent to treatment and sent to rehab. So it's definitely possible. But also, like, locally, Peterborough, what we're finding is, like, for instance, today there was a prison release who's on script. He'd been released with no mobile phone. He's not from this area. He didn't know where our office was, never mind how he was going to get there. And his nearest pharmacy that he can actually pick up a script that we're going to give him is a 45-minute walk that he has no idea how to get there, or a mobile phone to, like, use Google Maps. So I feel like at the moment this prison system's almost setting a lot of people up to fail before they even have a chance of doing anything with the drug problem and obviously the crime.
Thank you.
The reason I say about the prison is there's actually a gentleman who owns a Ferrari who turns up to pick the people up from as they get released from Five Wells as a reward for keeping quiet and so on. So you need to, you know, if they see that coming, that's an incentive for, the other way. So it is important to get in there early.
Thank you. I think under RAB it was residents. It's been changed back now to prisoners. I'll get to you, Councillor Lee. A couple of questions that I missed out before. And just a clarification, Helene. What's the proportion for NNC of that 2.4 million?
I'm very sorry, I can't hear you very well.
Right, sorry. What's the let's put it here. What's the proportion for NNC area of the 2.4 million allocated for this for substance misuse?
That's a question I need to look on my laptop for, so I've got it ready at hand. If you want to tell me your second question, if that's
no
okay,
Absolutely.
And then I'll look it up and come back to you.
This one is actually for a family support link, and thank you for that. I think in your area you're supporting family rather than the substance misusers. I just wondered how you support, how you measure your outcomes in that instance, and one for a Bridge. What's the occupancy levels currently with your supported living units? Thank you.
I'll answer first if you want.
Yeah,
if you want to look
thank
at that.
you.
So with regards, we looked for the young people's cohort. We carry out regular outcomes at the first start when we start engaging with support for them and see if those outcomes have moved. These have been measured through, we've looked at the Children's Society outcomes, and for adults we also use an outcome tool that was developed by, let's try and get this right, Velleman and Capello, who work alongside Birmingham University. Is a recognised tool which identifies the stress, strain and coping mechanism and support. So we identify that, and we do that at several points throughout the support for the adults, and the short Warwick scale, which looks at whether they feel relaxed, they feel comfortable, that they're stressed, they feel are they feeling isolated, and the aim is really by the end of the support those scores should improve. Obviously that doesn't always happen. But from an evaluation report that was completed in 2018, we carried out a piece of work that actually identified that we contacted previous clients that had not been in the service for 3 to 6 months, and their scores have continued to improve after support, so that their wellbeing scores have continued to improve because they've carried on setting healthy boundaries, continuing to engage with their support networks, and looking at how they to cope in different situations, and recognising that you don't just have to cope one way. It's okay to have a change approach if they want to, and that we were really pleased with that evaluation and those outcomes that came through, so we've continued to use that particular method.
Thank you very much. Thank you.
Yeah, so in terms of phase, we have 20 properties around the county. 13 of those are in the north. They're always occupied. We try not to operate on a waiting list system just because they're 2-year tenancies. We don't want people to sort of wait. In terms of a move on, we look at about 6 months from the end of that 2 years to move on. But because we can't always be sure of when somebody's going to be allocated another property, we don't want to put a waiting list. But there is never any problems in allocating those properties.
Good. Thank you very much. Thank you. Councillor Lee.
Thank you. I wondered whether, I've got several points, I'll keep it brief. I wondered whether there are enough spaces in rehab in the county. That's one thing, because I think there are just spaces in Rushton, isn't it? Isn't that the case? And I just don't know whether there should be more spaces.
Yes, I think Rushton is a separate organisation, but we use a range of rehab facilities around the country, and just to touch on Trina's case study, we would tend to send people a little way away from home. So the idea is that it's far enough away so that you can't just sort of pop out and head back to old habits, but not too far. But again, to the case study, people do tend to relocate sometimes with that. So in terms of the budget that we have for rehab, it gives us, and this is just a rough working, but 9 general places for people of low complexity who would have a 12-week stint at rehab. So the average length of time would be 12 weeks. What we, again, are learning as we go through some of this stuff, and again, looking at people who've been in prison, so to go back to that, who've often got like childhood trauma backgrounds, they've been institutionalised. We put somebody through a rehab placement that we took to the case study, went to the CDP group. He had 6 months of quite expensive, complex rehab because that's what he really needed, because that was what was going to make a difference, and it did. But again, that was some additional funding that came as part of the drug strategy Dame Carol Black review, which we were able to put somebody through that kind of rehab. But generally, we can put 9 people a year through 12-week rehab in standard rehab places.
Thank you.
So if I just add to that, the other thing that came through this additional money is around inpatient detox, what we'd call inpatient detox, and that's for people who need more medical support alongside some of exploring some of their issues. So that comes to us as a separate grant, but they're very specialised units, so we wouldn't expect to have one locally. We tend to use the level which is based in Nottingham.
Thank you. I also wanted to thank you for coming here. It's very powerful, the work you're doing, the stories you tell, and the role you play is so important. The role that volunteers play is so important. There's so many different groups, Al-Anon, AA, Narcotics Anonymous, and it's not at all, I think, a duplication. Some people feel more at ease in one group, as you say. In prison, I know someone who works with 12 Steps who's tried to get into prisons like you, and he just wonders whether maybe it suits the prison system that the inmates are sort of stoned out of their minds because they're easier to handle. It's a big issue that really needs to be tackled. About neglect. Neglected children, that really struck a chord with me because we see the number of neglected children increasing. So it is something we've got to be aware of the possible outcome. And if we want to prevent children, young people turning to drugs, we need to tackle the problem of neglected children. So it's very powerful what you've told us. Thank you.
Adam, did you want to say anything about some of the groups you've used? Because in our conversation that really struck me about the range that might help just one person?
Yeah, so, first of all, I want to say that even though we've only got 9 beds for rehab, we offer obviously community treatment that they can do with ourselves. And we never close the door, so it doesn't matter if 1,000 turn up, somehow we'd have to juggle it and make it work. So there's no cap on how many that we allow in our service. So there's no ceiling. If they come, we try and support their needs. But at the moment, so we offer on a Monday, I remember all these, so on a Monday we do Smart Group. Smart it's very similar to NA. I was an NA member, but a lot of people don't like the God bit and spiritual bit. So Smart takes away that bit, but still gives the same values and helps you tackle like the behaviours within addiction and triggers, and there's certain tools that we can work on in that. That's on a Monday. On Monday morning as well, we have coffee morning where people can just come, they can get a coffee, have a little bit of breakfast, and they can have a one-to-one if they want. They can access our needle exchange, any leaflets that they need. We can do any Hep C test, HIV test that they need to be done if they've not had that already. What else? Tuesday. So Tuesday we do Foundations for Change. So our Foundations program, our group work, it's really good. I know I'm work from some say, but because I went through rehab, it's very similar to what you do in rehab. It's a very similar group work. Rehab's all about group work 2-3 times a day, and these are very similar groups that you do in rehab. So we offer them in the community. And then Tuesday evening, we do an online group for Smart. So that's people that can't actually access our service. So I think that's 6 till 7:30 at night. On a Tuesday, that's online. Wednesday, we do Welcome to Recovery. So everyone that accesses our service, we invite them to Welcome to Recovery. And there we tell them what we offer as a service, what our pathways are into treatment, and a little bit of what we expect from them whilst they're in our service. Straight after Wednesday still. So then we have Foundations for Rehabilitation. This is normally for people on probation, or they've been had a conditional caution at police station, so they'll be referred to us and they'll be going on to that group. Also, DRR go on that group. And then Thursday we do Foundations for Growth. Foundations for Growth is after change, so you do 10 sessions on change and then you move on to growth. So change is obviously learning about you trying to change things, and then grow, giving them a bit more about like the trauma and making them think a bit more. Where are we? Thursday evening we do our Foundations group, but we do it online for, again, the people that can't access our service. And then Friday in the morning we do an EBI group, which is early brief intervention. So that's a 3-week group, and that's just really for people that are first entering, a bit nervous about groups. They're normally quite a small group, and that just gets them ready before we move them on to Foundations for Change. And then we also have acupuncture on a Friday. So we've got 2 members of staff in most hubs that are trained to do acupuncture. So they put relaxing, I've not actually done it yet, but they put relaxing music on and do acupuncture, and a lot of our service users really enjoy it. And I think that's all we do for groups, off the top of my head.
Thank you very much. It sounds like a comprehensive list of services, and credit to you for remembering them all. Councillor Brown.
Thank you, Chair. Just like to start off by echoing some of the comments from the other members about you coming here today and sharing your story. I appreciate it's not an easy thing to do. It's pretty daunting to talk in front of all this lot. But it's really important that you do it. I mean, so often in these committees, we're looking at statistics and numbers and money, and it's all quite cold and harsh. So it is really important that we hear these stories and get these experiences. It's really worthwhile for us members. Saying that, I am going to go and revert back to the numbers and the figures now, I'm afraid. If I can draw your attention to 4.6 on the report, this was in regards to the near 17,000 attendances related to drugs and alcohol by 6,000 individuals. The sentence of 40 of these individuals has attended 25 or more times. This kind of struck me really because I'm an engineer by trade, and we do something called Pareto, the Pareto principle, which basically says, you know, you're familiar with it. This is good. 20% will cause 80% of your issues. I was just wondering, and I'm guessing by the way you're nodding your head, that you do utilise it and you're familiar with the principle.
I wouldn't say we utilise it absolutely with what you're talking about. And sometimes in terms of hospital, we talk about people who are frequent flyers. It's not the best way to describe somebody who's coming to hospital frequently. But it is absolutely something that we're trying to pick up from a service point of view. So Ali or Adam talked to you about having nurses that are based in the hospital. But the other part of this is everything else that goes along with the health needs of somebody who may use drugs or alcohol for a long time. So I think we still have an opportunity to understand more about this group of people. Because some of when we were talking before we came in, if you've smoked for a long time alongside using drugs, if you've not cared for yourself because drugs have been the primary importance in a sense, if that's a fair way of talking about it, then your physical health isn't good. But there's lots of work. I always feel it's a bit like pulling a thread. There's lots of work where we're pulling a thread at the moment, and this is absolutely an area where we'd like to know more. But again, we really need to work with our colleagues. So working in this case with hospital-based colleagues, and Jane could talk to you about work elsewhere alongside liver specialists, for example. It provides an opportunity, and we need to maximise it, because what we want to do is any of these people becoming one of our statistics, whether, a drug-related death, an alcohol-related death, an overdose. So it's absolutely about understanding the opportunities, but I think we've got more to do to make the most of that.
Thank you, Councillor Brown. I'll get to you in a moment, Councillor. I wanted to ask, around 4.8, the percentage of male deaths seem to resemble the percentage of male suicide rates across the UK. I just wondered, which is about 80% men, about 20% women, the Samaritans, as of the 31st of October 2023, for the 2021, but at around 359 males, 74% for the ONS. So it seems to be linked. So my question is why? Is it solely deprivation, or are there other concerns like purpose and opportunity, maybe change in the societal framework? Is there more? Is there more that we can do to dig deeper as to the causes? Sorry, there's a higher percentage of males that are dying from drugs, substance misuse.
So I'm going to give you in a sense, the statistical, the evidence background, but then I would like to hand over for people to describe that from their experiences. So historically, what we've seen, particularly in opiates, so things like heroin drug use, it has been more common in men. And what we've got now is a group of men of a certain age who've used drugs for a really long time, because you talked about, starting in the 80s. So what we're seeing is a population whose health haven't been good for a very long time. And that's who we're also seeing in service, because we've got an overrepresentation. And when you see a similarity to suicide, we do know that there is a real crossover between people with mental health needs and people who use drugs or alcohol. And often, as services, we don't meet those needs as well as we can do. And we know that for people who do take their own life, not necessarily being a user of a substance misuse service, but drugs and alcohol can be a feature around death. And we know that still in our society and in many cultures, men find it more difficult to talk about the things that challenge them. When we've talked about childhood trauma, when we've talked about neglect, when we've talked about a lot of those factors, we're seeing some of that play out. But I'd like to, pass to colleagues here to talk about why we might see more men in some of that, men in services, or more men using substances.
I had my second stroke in 2009 through drugs and alcohol, and that's what happens really, doesn't it? Know what I mean?
I don't know how to say, really. There you go. Oh, yeah, so I'd like to say, I don't know if it's like a man thing, so I was abused as a child. And then I managed to flee and come back to England because I was in another country and was brought up in social services from the age of 11. And then as an adult, I was obviously subject to a lot of drugs and stuff and criminality going through the care system. And then as an adult, I've been sectioned. I was on antipsychotics and stuff. And actually a lot of that was probably because I didn't speak about a lot of things. I tried to use drugs to deal with my issue instead of speaking about it. Maybe females, I don't want to talk for females, but I'm in the middle. But maybe females, it's easier for them to maybe open up. And when you come from maybe especially abusive, where if you cry you get beaten more as a child and you can't show any of that fear, or I think maybe without us realising it, it builds up over years. And then it comes into your adult life because you don't deal with it, and the mental health service from a child doesn't really deal with it, and so I know what battles you go through because I've been through that system. It's hard to put exact thing on it, but I think it takes a lot of services to communicate and help more and tackle more. Like I was sectioned 3 times. They didn't help with my substance misuse, which was the main reason that actually led me to being crack psychosis, was taking drugs. So they had opportunities there and it wasn't really picked up on or dealt with. There was no aftercare, like counselling and stuff like that, offered to deal with actually the trauma that I was using the substances to try and numb, which it's really hard for us as a service because we have a lot of people coming into our service with all these traumas still from their childhoods. We have females that have been gang raped, we have from county lines, we have a lot of serious traumas that these people are now using drugs to, and it's really hard for us as a service to get other agencies that can deal and tackle with that because we can't, unfortunately. We're not counsellors, we're not psychiatrists and stuff. We're substance misuse recovery workers, and I think that's where family support come in. I do referrals to them because these people's parents come in and ask us, why is my kid doing this and why, and it's hard because we're there to help their kid, we're not there to help them, if in the greatest of respects. Which is why we're funded by the local authority to help their kid, and it's really hard, and especially if their kid refuses consent, then we can't discuss anything. So it's really hard for a parent to understand that, and that's where I think family support come in and are amazing.
So if I could just pick up on that quickly, sorry. Just around that as well, we, often when parents come in, we're seeing an increase of adult children with parents that are coming along, and there's that guilt. What have I done wrong? Why is my child still using drugs after 20, 30 years? What did I do wrong? And it's nothing. They've done nothing wrong. There's been a loving home life. It's just a circumstance. Nobody chooses addiction. People make bad choices, but they don't choose addiction. And as Adam was saying, just to give you an example, recently a client was sadly bereaved due to her husband dying due to alcoholism, and she felt that she had more sympathy if she actually told people that he died from cancer. Because if she told people that he died from alcoholism, she got O. But if she told him he died from cancer, there was empathy and there was sympathy. Thank you.
That's very insightful, very pertinent. Thank you. Councillor Maxwell.
I've got a few questions. Sorry about that. So the first question I've got to ask you, just how many children do you actually deal with, children who are at school who have got alcohol abuse? Right. So how many in this part of the county, NNC, do you actually deal with, roughly?
So if you haven't got a precise number with you, an estimate, or we can get that number back to Councillor Maxwell.
And the children that you actually deal with who have either alcohol or drug abuse, do the schools actually know that these children are suffering from this type of behaviour?
Yes, so if I take the last point just to say, because that came up in one of the other conversations, we have a higher than average, national average referral rate from schools and education providers. We have really, really good links and are really well embedded and established with the education providers in the north as well as the west side of the county. We have you got the numbers there, or are you still finding it?
I've got them for the combined, not
for the
specific
combined,
for
yeah.
the north, but in terms of the number of young people hit, in terms of the number of young people that we saw through our group provision, which is co-produced with a college and other young people in terms of a delivery, was nearly 4,000 young people. That's drug and alcohol education within schools. We obviously then, as a consequence of that, and obviously through other referral pathways, we do then see young people for more structured treatment, that our workers go out to schools to see them within schools as part of their support. So where someone needs a little bit more, then we will obviously offer that as structured support.
And are the schools actually, do the schools operate collectively with the children? Do you actually get involved with the teachers and the children individually, or is it in a group session?
It's mixed effectively. So we offer the group intervention, which is where we've seen kind of over 4,000 young people within schools. But then, like I say, we do offer the targeted intervention, which will be on a one-to-one with young people. And that will work with them individually, so they'll get an assessment, a care plan, and we'll work on their individual needs. We try to work holistically, so as part of our work, we include other professionals in that. So sometimes that's the school, sometimes it's mental health professionals, obviously parents are a key factor in that, where it's safe to obviously include parents, and wider family members. So when we assess someone, it's not just about the substance misuse, it's about all of those other wider factors. So our service will operate in that way.
We do. I was just going to say, and knowing that the local schools as well, we do work really closely with teaching staff, but actually also the pastoral and safeguarding teams within the schools. As I said, they're our highest referrer into us, and we work really closely in sort of MD team meetings, but actually really do form a team around that family, and we'll work with other services such as the Trust to trying to bring in and support the wider areas of concern for that young person.
Are you surprised then the amount of children that you're actually dealing with now within schools? And to me, it seems to have increased. Children seem to have increased in numbers with alcohol and drug abuse to perhaps what it was 10 years ago. Do you think that's the case?
It was on the decline, wasn't it? And it is slowly coming back up. I think there's a lot of factors around that. The conditions for mental health and the shortfalls in mental health treatment. Children and young people are self-medicating. And there are many, many reasons for that, right from COVID, and we are seeing year on year the impact that COVID has had and the trauma it's produced on our children and young people, and the way that they're learning to form relationships and social skills, right through to more complex issues, to the cost of living and obviously the prominence of County Lines targeting our children and young people, but actually making significant efforts to target our primary school aged children now.
Just to add to that in terms of COVID is the accessibility. So people being locked away, young people and other people who use substances had to be creative and use other means to access substances. So I think the accessibility of online, being able to order certain substances, I think increases that accessibility to young people. And we have a generation who are very digitally savage. Savage, I use that word, savage, they are all about digital media and social platforms, etc. So that accessibility is another thing that has kind of spiked out of COVID, I think.
And the other thing is that, given the fact that you go around like Corby, Wellingborough, Kettering, but you don't go to the villages as such, and in the villages, which is where I deal with, so I met a group of 12 people last week who virtually had nothing to do, and it seemed quite interesting to perhaps take some drugs. So I'm looking to try and do something for them. But I think, it's a massive issue. It's, underneath, these villages which get cut off, there's no route to buses or anything like that. Therefore, it's very difficult for them to commute. And I think it's an issue that's increasing, but you don't actually see it because it's undercover. Can I just ask lastly, does your funding come from NNC?
So our funding, so we've talked about two different sorts of funding. We've talked about the public health grant, which is the bit, in a sense, our ordinary funding. And I talked right at the beginning around that being mandated. So yes, that comes through the NHS, but comes to local authority public health because we commission those services. And then the Office of Health Improvement and Disparities, I don't think you could easily say, right, this is an NHS stream of funding or this is other parts of government, because the Supplementary Substance Misuse Treatment and Recovery Grant, snappy title, that sort of, in a sense, was multiple government intervention. So it's not a single stream of funding.
Do you not think if you had a budget from NNC specifically for this would clearly help move forward with dealing with younger children?
I wonder if I've misunderstood your question, Councillor Maxwell. I thought you asked me if how the money flowed into Northamptonshire from the national government.
No, I was asking you, do you specifically, we get money from the government, do you specifically get money from NNC to actually fund helping younger children?
So the public health grant comes into NNC, and the public health grant is then spent on a number of these different things that we've described.
Yeah, thank you, Councillor Maxwell. I think it's within the report about 2.4 million is the share for Northamptonshire, and I guess that will may help Councillor Maxwell for the share. Did you manage to get the share of the NNC?
So the way the money flows, and I wanted to double check before giving you an answer, is it flows to the former Northamptonshire district area, because the baseline was when we were a single. Northamptonshire was not in the formation it is now. Yeah. So the money comes down based on those aims. It doesn't come down simply based on geography. So it comes down on increasing people into treatment or thinking about some of our work with young people in recovery. But as you would imagine, when we're developing those plans, Jane and I are very keen that we make sure that we're meeting the needs of people in North Northamptonshire. But unlike other pots, it doesn't come down in that simple division.
Just to add to that, in terms of assurances, the way our contract is managed is we do look at that geographical split. So we are contract managed in terms of ensuring that that central pot is distributed and the support that we provide goes across north and west. So our KPIs are split to show that we monitor the delivery across both elements. So just to offer that kind of assurance, really. And to say if there are any gaps, just on one of the previous points that you mentioned, if you're identifying anything local, please get in contact with us, and if we can support in any way, because we're not already there, we will by all means do what we can to support in those spaces.
That's really good. Thank you.
Can I just say one more thing, please?
Of course. Go on, Councillor Maxwell.
Can I just say that, so at the moment, it's different from what we were before, where we were kept in Wellingborough and so forth. So now we are two authorities, west and north, and our budgets are north and west, so they're separate. And what I was wondering was that we are north, therefore our budget is specifically for north. Does the funding from north come to you specifically for children who have drug and alcohol abuse?
So some of our funding arrangements haven't devolved into the geographies that you're describing. So at the moment, in terms of our course substance misuse contracts with the organisations that you see here, West are the lead commissioner on behalf of West and the North. And in other areas currently, the North are the lead commissioner around our public health services for children, for example. And I know that's perhaps not as easily described as an answer as you might like, but that, although our public health grants are separated in the way you described, they're a direct allocation, we have got commissioning arrangements that are legacies from previous organisations. But in terms of making sure that all of the services you see deliver the best service they can for people who live in Northamptonshire, that's absolutely what we do. And sort of Emma's described how we monitor some of that.
I'll just go to Jane to
Thank you. If I can just build on that a little bit. So we have a public health grant that we need to make sure meets the right people in terms of need. And so, for example, for children and young people, we will say this is how much we've got to spend on children and young people's services, and then we will work with providers like Engage, who've been so eloquent in describing their services this evening, and they will get part of that. They will get that funding to make sure that is delivered. What our job is as public health is to work really closely with the providers to have a really positive relationship, so that we're always looking at what else could we do, what's innovative. And what I would say is, as Director of Public Health and responsible for these services, is there is a really good functional relationship between the services and also between us. And what I would say, Zoe and Emma, is we had a recently very complex safeguarding issue with a young person, the most complex I have ever come across. And the way that the services responded to that jointly, so we had, with Zoe and Emma and Engage, absolutely pushing for and advocating for that young person. But we also had our amazing colleagues in CAMS at NHFT, we had involvement from children's services, we had a whole range of people working around that young person. And we only get that right by working together in the most positive way we can. So part of this is about getting the funding right and making sure the funding is used in the way that we want it to be used, and we do that through contract management, but the relationship is just as important. And I think that some recent examples have really shown how important and strong those relationships are.
Thank you, Jane.
To that, we don't actually see where the funding is. I mean, we listen to the budget, but we don't actually see how it's actually spread out and where it physically goes as councillors. And I'm thinking, I'd like to see more transparency. I'd like to see that the funding definitely goes to the people here who actually work with these children or adults or whoever they are, so that we know that it's being met. That's what I'm asking.
Yes, I completely agree,
please.
and I can give you assurance that we have contracts in place with Engage and the money does go to them. I think the other thing is if councillors are and members are interested in learning more about services, we've got a really fantastic opportunity to visit services and to go out and see and speak to different people. So I think that's something else that we can offer. But certainly when it comes to, so budget scrutiny, for example, we talked about how much we spend on these sort of services, but I can assure you that we have a contract in place for young people's services. The provider is here with us, and that's where that money goes.
Thank you. Councillor Lawman.
Just a couple of points. I've realised that one of the local area partnerships has actually got a working group with on substance abuse, and the officers are nodding, so they've obviously. But if the various schemes here are able to support them, I'm sure they'd be grateful in the work
and have. But we so I think. I assume you're talking about Wellingborough?
Yeah.
Yes, and we have linked in services. It's very important that the voice of the service is understood by the people who might use the service and have a passion. I've also spoken to one of the leads to really understand where some of that passion, in a sense, is best directed. It's good to understand where people are coming from so you can support.
Sorry, that was an aside. I wanted to make a comment about something else, and I don't expect anybody to answer because we'll be here all night if you do, but councillors are corporate parents, and which gives us the overall responsibility for, and it just worries me the number of times, and it was just said earlier, the number of times we hear that people have been let down in the care system, and they come out of it in as bad, if not sometimes worse situation than they went to. And we heard earlier it's not for their own fault often that they went in. And that just is a big concern to me, and I think it's something we should be looking at as to why that happens. I mean, hopefully it doesn't happen much in Northamptonshire, which is our remit, but and I don't expect anybody to particularly answer it, but I think it is something we need to bear in mind and look at and be mindful of.
If I just coming very quickly on that, the example that Jane gave around a complex young person who might need additional support, what we all know is how we elevate if we still have concerns, and David was able to intervene and support. As services, we're absolutely alert to where there may be vulnerabilities and keen that we would communicate with each other to minimise any ongoing harm. That's not a simple answer to something that's complex, but I just wanted to make sure that we had that commitment, and alongside lots of other things that we manage through our contracts, making sure everybody's really confident around safeguarding children and vulnerable adults is absolutely part of that.
Thank you for all the speakers and to the members. I think we can talk about this topic all night. We've been here for quite some time already on this topic, but absolutely vital. I do have one question, one final one. On 4.11, how do the LDIS get their information or reports of the circulation? So if there is something circulating, how do they
I'm sorry, it's my hearing, I'm afraid. I didn't hear you again.
4.11, how do the LDIS get their information or reports of the circulation of the new harmful drugs? How's that fit in?
So in terms of how that works or how it appears or what we're seeing, I'm sorry that I can't hear you
apologies.
very well.
Let me try and reframe that. The harmful drugs in the system that circulated, the LDIS are responsible for identifying that and informing service providers. How do they get that information initially?
Okay, so a service, usually, sometimes the police, fill in a form that describes what's happened. So this might be somebody that's overdosed, it might be somebody who is in service and when they're urine screened that they pick up a substance which isn't the substance that somebody thought that they'd had. That report comes into me and colleagues. Depending on the nature of that report, what we do is convene a meeting that governs the sort of actions we're going to take. and then we communicate with a network of people who've signed up. And what that will include is some harm minimisation messages. So we know that if we want to reduce harm, absolutely, that's about not using an illicit substance. We know that isn't a message that will work for everybody. So there's a range of things that we would encourage people to do that will reduce the harm, alongside making sure, if we can, that people come into treatment, so both into a treatment service, but also think we've talked quite a bit around naloxone, because often the greatest harm we see is from opioids, so things like heroin. And what we then do is increase understanding across our network. So it might be if somebody comes into an emergency department, that staff have in their mind that somebody might report using benzodiazepines or something like diazepam, but that isn't how they're presenting, to think that possibly this could be an opioid-related overdose. It's been a busy area of work because, again, going back to what Jane said around relationships, what we've got is people who are really willing to talk to their service provider about the drugs they're using, and we've got good communication amongst ourselves. And sometimes we might take more specific action. So you might remember some of the news coverage just before New Year and into the New Year in terms of seizing some illegal substances in Northampton, and that was on the back of a cluster of reports we had on the morning, and the police then acted very quickly, which comes back to one of your original points of, how do we work, collectively with the police, and that's a very concrete example.
That's very good. Thank you very much. I think we've exhausted this now. Thank you, speakers. Thank you for participating and giving us your experiences. Much appreciated. Thank you. We'll move on to the next item of the agenda.
Chair, is it okay for people to leave now?
Absolutely, yes, of course. Yes, please, you can.
We have kept you a long time, but that's useful.
And I'm going to leave and rejoin, but I promise to do that very quietly.
No problem. Thank you. On to the next item 5, NHS health check. I'll pass it to Jane to...
Thank you, Chair. It's actually going to be Andrew, a commissioning manager, who's going to do the presentation. But just to give a little bit of context, so NHS health checks are one of the few mandatory things that we absolutely must deliver. And it's about, Andrew's going to go into a little bit more about what they're about, but they were initially set up to try and reduce premature mortality. So that means death below the age of 75. And it's something that public health have to commission, we have to provide it. It's never an easy area. And one of the issues we've had nationally with NHS health checks is uptake. And this is partly because of, we can't force people to go for an NHS health check, but also because people are sometimes struggling with access to primary care. And certainly for us, a lot of our services have so far been within primary care. Andrew's going to present today just some key information about the NHS health checks. And I know we're a little bit short for time, but hopefully we would still be able to have some discussion. So thank you, Chair. Over to you, Andrew.
Thank you, Andrew.
Thank you, Jane. Yes, as Jane mentioned, I'm just going to run through a bit of a briefing relating to NHS health checks, beginning with just some of the basics, really, how the health check's structured and what a health check looks like. So an NHS health check, as Jane's already mentioned, is a national programme. And it's designed for patients 40 to 74. It's designed to spot warning signs relating to diseases such as type 2 diabetes, dementia, heart disease, as listed on the slide just there. The NHS health check is designed for patients that we believe are otherwise healthy, and to identify risk factors and then work with the patient in that 20 to 30 minute appointment to lower these risks. Next slide, please. So the NHS health check should be delivered with each patient every 5 years, as mentioned, between the ages of 40 to 74. When a patient reaches the age of 75, they will drop off that list of eligible patients and should be in receipt of more regular health checks or health checks related to their condition instead. The NHS health check offer we're talking about today. If a patient is diagnosed through a health check or through any other screening process or appointment with a condition that the health check is looking for, they will also become ineligible for a health check, and again should receive more suitable forms of support to help manage their condition and keep an eye out for other health concerns. So, as a rule of thumb, NHS health check is for people that, at least by their patient record, are otherwise healthy. So in North Northamptonshire, GP practices are responsible for inviting patients for the health check. Since COVID and since people have got perhaps a little bit more used to using technology to manage their health and well-being, patients more often than not invited to the health check by text message now, something we're encouraging GP practices to do. It's still not uncommon for a patient to receive their invite by letter. And often when GP practices are chasing non-responders to their first or second health check invite, practices where capacity allows will follow up with a phone call to try and sell the health check a little bit more effectively than perhaps a letter or a text message has. Next slide, please. Slightly complicated diagram if you've seen it through the first time, but I'll walk you through it briefly. The orange section at the top, for those that can read that small text, is the health check appointment itself. The patient will be asked a series of questions relating to their family history, physical exercise, alcohol consumption, as well as have some physical checks, including their blood pressure check, a blood test, measure height, weight, and so on. And during the health check appointment, looking towards the right top side of this diagram, the patient's results will be recorded on their clinical record before moving on to the bottom half of this diagram in the blue, where the patient may need a follow-up appointment and will have some clinical risk management, either through medication or signposting referral lifestyle advice if required, or a further clinical assessment. Just as an example, if a patient's returned a high blood pressure measurement in a health check, they will go on to have a full hypertension follow-up with either through their GP or a nurse. Next slide, please. So currently in Northamptonshire, we have a joint arrangement with West Northamptonshire. As far as the NHS Health Check programme goes, Northamptonshire Council is the lead authority. But this arrangement is set to finish at the end of this month. A report came to executive back in August time proposing the disaggregation of the contract, which we have nearly seen through now following that approval. So come 1st of April, we will enter into new contracts with some existing providers and some new providers to take the NHS Health Check programme forward for North Northamptonshire only, and West Northamptonshire, of course, will have their own arrangements. Next slide, please. So currently these are our providers. The ones ever so slightly greyed out are providers in West Northamptonshire that we still support with the contract monitoring of. But I'll walk you through these quickly. So our biggest provider is 360 Care Partnership, who manage 25 of our GP practices in North Northants. And then we have one practice under the Maple Access Partnership Group, three, including the site local to here, under the Lakeside Healthcare Management, one practice, Wansford and Kingscliff, and then Rushden Medical Centre. And as mentioned, one's greyed out are West Northants, but they're there just for information. Next slide, please. We have 4 community providers, a pool of community providers we're looking to increase over the next year or two, and definitely through this phase of commissioning. Just some context, our community providers deliver health checks away from primary care. So the vast majority of our health checks are delivered in a GP practice setting. But over the last few years, we've been working hard to try and increase patient choice, deliver health checks through a form of outreach, and especially in the case of Northampton Town Football Club, which I'll come on to a little bit later, in a workplace setting as well. So taking our health check offer to factories, warehouses, schools, and more to deliver health checks through means it's convenient. Regional Pharmacy and Emergency Care Gateway are pharmacy groups, and they've been supported in delivering health checks alongside COVID vaccinations, with their patients visiting the pharmacies as well. But both are new to the health check system, so haven't been with us for too long, but are doing some good work. University of Northampton is our final provider. Due to the size and scale of their staffing structure, they were just delivering health checks with their staff at the university, but they have been inactive in the past few months, and moving into our next contract, and with them being outside of Northamptonshire geography, I don't think they'll be continuing with us. Next slide, please. So we have 2 support contracts for the NHS Health Check programme. We have an IT solution that supports the Health Check programme at all levels. They provide software for use in GP practices to help them manage their caseloads and invite their patients. And they also provide us with a data solution to help manage the programme as commissioners. And we have a contract with a company called BHR Pharmaceuticals, who provide point-of-care testing analyzers, consumables and control measures, which allow for all of our providers to take cholesterol and HbA1c measurements at the health check. HbA1c, for those that aren't aware, is our measure of type 2 diabetes. Next slide, please. So I wanted to mention COVID-19 for a couple of reasons. In Northamptonshire, of course, when COVID struck, we were still managing the health check programme on a Northamptonshire footprint. The NHS Health Check programme, as it was nationally, was paused, and we struggled to recover from the pauses to the health check programme due to our predominantly primary care-led model. Our GP practices were reluctant to reopen their doors as they once were for something they saw as non-essential for quite some time. But we've been keen to stress the importance of the health check, both with COVID not going away and the impacts of poor health and lifestyle choices alongside COVID. So we saw people that perhaps smokers or people carrying excess weight or people with other long-term health conditions being disproportionately affected by COVID-19. So for us, although COVID had a negative impact purely on our performance numbers for the health check programme, we're really working with providers to emphasise the importance of the health check to mitigate against the impact of our health and wellbeing choices in the event of illness such as COVID-19 moving forward. Next slide, please. So just wanted to touch on our performance data quickly. There's three performance indicators I'll discuss quite quickly, and happy to take any questions as to these towards the end of the presentation. The first one is our offers data. So our offers are the first invite a patient will receive in a 5-year period. So that letter or text message that the patient is likely to receive. And I've drawn comparison here with the England average against Northamptonshire. And we are both above the England average in terms of the invites we're sending out to patients, but we're also above our locally and nationally set target for NHS Health Check invites. Next slide, please. And just to, as you've probably noticed on each of these first 2 graphs, we see that big dip is our COVID interruptions, and that staggered increase also reflects the challenges our providers have faced in terms of feeling comfortable opening their door to patients again for the health checks. But this the second graph here is for our NHS health checks received. So these are health checks delivered with eligible patients. We're in line with the England average at the moment, so definitely not an outlier either way in terms of our performance. But as with the offers, again, you can note here our slightly slower recovery as our GP practices gradually open their doors again, slightly later than perhaps some of our colleagues around the country. But we are absolutely back on track and in line with the East Midlands average. The next slide, please. Slightly relating to what Jane said earlier about uptake, this has been one of our more challenging areas, and again, as Jane said, it reflected nationally, and it's not a challenge unique to us. We have, although there's no formal national targets relating to uptake or health checks completed, typically and locally we do have a target of working towards 60% uptake, and we are down we're at 38% and compared to a 40% in England average. I don't want to jump ahead too far in terms of the slides, and if the slides don't cover it, I can't remember what I'll put in the next few. I will discuss what we're doing to try and improve uptake locally. We do have a couple of approaches towards this. For the time being, happy to move on to our next slide. Okay, so these are a few of the current challenges the NHS Health Check is facing. Staff turnover in primary care has proven a massive challenge for us. We're in a bit of a cycle of training up our GP providers, and by the time we've moved on to another one, we're going back to the same practice we were at a few months ago and offering them the same support we once did, because HCAs have come and gone. And of course, when the clinical staff delivering the health check leaves, the program is then prone to perhaps falling away for a few months or slowing down substantially, which does have an impact on our data. Winter pressures do have an impact on the NHS Health Checks program. It is typically one of the first things within primary care to be deprioritised. So when it's time for the flu jab rollout, or when clinics become particularly busy, NHS Health Checks are one of the first things to be paused. From a local authority perspective, inconsistency is a big challenge for us. Although our invites data looks quite strong, and as a local authority it is, we're not always achieving that through having each of our GP practices invite a steady number of patients. We tend to see one practice significantly over-invite, which mitigates against a practice that's perhaps under-invited. Clinic capacity and a need for urgent appointments is, of course, a challenge for us. Not that we want urgent appointments to become any less available, but that they do need to be prioritised, and often this is at the expense of health check appointments, which in turn does affect our uptake. And accessibility of the health checks, as I mentioned a few seconds ago, not every GP practice is offering the health checks routinely, and some practices will under-invite for their health check program, or might not be running it all for a period of time. And when they are running the health checks program, they are inviting in order of clinical risk. So there's not a huge amount of opportunity for opportunistic appointments if someone is curious and would like to have their health check without having had an invite. And equally, this is one of the things we are putting some effort into supporting our providers with. We do have concerns about the accessibility of our invites to perhaps patients that aren't native English speakers, or have other accessibility requirements relating to their reading ability, or even access to technology, access to transport, and so on. Next slide, please. So we have a workplace NHS health check program of work at the moment, and it's been a much bigger success than even I anticipated or could have hoped for, to be honest. And it's led entirely by Northampton Town Football Club Community Trust, who are the charitable arm of the football club, of Northampton Town Football Club. Although primarily based in Northampton, of course, that they do run health and wellbeing interventions across the whole county and do a lot of work across North Northamptonshire, and will be continuing to do so as we move into the new year, into the new financial year. The football club reach out to workplaces, specifically targeting routine and manual workers that perhaps find it difficult to get time off to attend a health check appointment as they usually would, perhaps would shift work, family commitments, long hours. So we're taking the health checks to them. Across the county, we have delivered 881 NHS health checks in workplace settings in around about 18 months. And just to illustrate the importance of them, 154 patients have been identified as having a raised CVD risk score, so clinically at risk of a cardiovascular disease-related issue, and 18 of those were identified as having a very high CVD risk score, to the point where we'll be looking to have them exit the health check programme onto a more controlled and closely monitored form of support from their GP, perhaps medication and close monitoring from that point onwards. So the Workplace NHS Health Checks programme has worked very well. We've got a very good relationship with the community trusts that have been delivering the programme, and if anything, they're looking to expand their offer for North and West Northants as the relationship continues to develop. Next slide, please. So I touched on the community health checks earlier, delivered by our pharmacy groups. We're very keen to make sure that our patients in North Northamptonshire have choice. So the health checks program isn't monopolised by the GP practices, meaning patients can access the health check at a pharmacy, at a community venue, at their workplace. And it's something we're keen to expand, but we are finding options for partners to be relatively limited. Difficulties around this approach, primarily the payment model. We pay £22 per health check and £2 for a first invite. So if that clinic is empty, the provider goes without payment, which is a big challenge. But we do have ways in which we can support providers to make sure that this isn't the case. And also, with a relatively limited budget the providers have for delivering the health checks programme, advertising and marketing the clinics can be quite challenging too. Next slide. So, service improvement plans. Next week, we are delivering a large training session for all of our practices across Northamptonshire. We are hoping for all HCAs and nurses are available in the protected learning time that the GP practices have. We're hoping that they'll dial in, have a bit of a refresher session on the NHS Health Checks programme, reintroduce them to our partners who I mentioned earlier, who supply our IT solution and our point-of-care testing solution, and of course reintroduce ourselves as commissioners and almost have a bit of a relaunch of the programme as our new contract comes into place. I discussed earlier some of the issues around the invites process and perhaps some of the challenges around non-English speakers or where there's other perhaps difficulties communicating the importance of the health check. So we're doing some patient engagement work at the moment. That's in progress to understand from a patient perspective what are the challenges of the health check, what's appealing, why didn't, if you've had a health check invite, why didn't you respond to it? We want to learn from the patients and from the GP practices as well, what's working and what isn't. So perhaps we can work towards both unifying our invites process and also having more choices in how we invite patients and a greater choice of languages for our invites and other accessible formats for the literature we're going to be sharing. Moving forward, we have been anyway, but we're looking to have a more robust audit process for our primary care providers to more closely monitoring their performance relating to the programme. And keeping a closer eye on their responsibilities around quality control checks and other areas of their health check responsibilities. And we're in a good position to do that. And now our staffing restructures are complete and we've got greater capacity in the team to support with such tasks. Next slide, please. I believe this one is my last slide, but just one eye on the future, and most people in the room probably aware that digital health checks are being considered, piloted, and moving into a beta phase of testing across England. The digital health check has been designed to support the face-to-face health checks and provide means for patients to have their health check within the comfort of their own home. There's still some pilot programs being run up and down the country, so it's far from being rolled out on a national level at this point in time. But we're monitoring the situation closely. We would like to take the opportunity to become involved in any pilot test for the program if the opportunity presents itself. And then when we are in a position to integrate it into our offer, we'll be looking to do so. Next slide, please. And that's my last slide.
Thank you very much, Andrew. Thank you. I just wanted to say, so I had 3 questions, and I think you answered 2 questions within your presentation. The one I do have is, do you work with, all practices, all GP practices within Northamptonshire?
Yes.
Thank you. Councillor Lee.
Thank you. I found an article, LGA has expressed itself against digital health check, saying it's not a replacement to in-person appointments. I do find, there is the weighing, you need accurate scales, there's the blood pressure. Already these appointments are very scaled down, there's no urine check or anything. So I wonder, is that maybe one step too far to go digital?
I'm part of so I don't want to speak against digital health check, because I do think it has a place within the system personally. However, I'd be lying if I didn't perhaps share a few of those concerns, and I think that's what the pilot testing in different local authorities is trying to iron out, I suppose. I think that the first pilot test was in Cornwall, and their immediate feedback was challenges around taking your own blood sample at home and running that test and posting it back. And again, being asked to go into your GP practice or a pharmacy to take your blood pressure and go home. Whilst you're there, it would have been nice to just have an in-person health check and discuss that. I think there'll be some challenges for us around effective signposting and referral making, because obviously what our local services, perhaps taking our weight management services, for example, they won't be the same as they are in West Northants, let alone the rest of the country. So it is making sure that if we identify someone that's perhaps has BMI 30 plus and is obese, that we can effectively still signpost them into our other funded services on what is likely to be a national NHS app. So plenty to work through. I see Jane wants to come in.
Thank you, Councillor Lee. I think that what I would want assurance on is where the opportunities lie to have that critical conversation with somebody. So what NHS health checks are really good at is detecting things like undiagnosed hypertension, and we know if we've got high blood pressure, that's a really bad thing. But what they're also really good at is those conversations about, have you thought about reducing how much alcohol you drink, or have you thought about stopping smoking? All of those conversations are really critical, and I'd want assurance that the digital programme allowed for that to still happen, because that is really important, particularly if we think about the prevention piece that we're so keen to push.
And just to add to that, really, I've been in commissioner manager role since August, but before that, I was still working very much in health checks, but on an officer level. My involvement was very much on the ground, working with the GP practices closely, doing spot checks and training with them. And one of my, as Jay mentioned, was always the so what element of the health check. You know, we're taking all these measurements, we're taking blood samples, doing blood pressure checks, and what are the conversations we're having with them, and that will continue to be one of our priorities to make sure, you know, these are a good use of patients' time. So it's absolutely something we can monitor as we move into a bit of a digital era with health checks, for sure.
Thank you. Councillor Norman, please.
Yeah. I'm just a little bit confused, it may be me, but it starts off in your slides saying that GP practices will contact us, and I fall within the age bracket, just about. It then says that you work with a certain number of providers, I think the 360 group, which seemed to limit it, and I wasn't sure whether what the difference was between the ones who've got a slide that you work for and all. And I can think that I've never, ever been contacted by my GP or my practice to come in, which is, and picking up on Councillor Lee's point, I mean, there are other things like bowel cancer, things that could be done at the same time, not just a urine test, but an obvious one. But I'm just concerned that how many people are really being contacted if somebody's been living in 20 odd years here and falls in the category for all that time isn't contacted.
It's one of the consequences of inconsistency between GP practices, and although we're reaching our invites target at the moment, but we haven't historically, and that's going back to Northamptonshire County Council days. Our invites performance is as good as it's ever been, but as I perhaps touched on earlier, that's perhaps down to some practices over-inviting, making up for some that aren't. So if there's any consolation, practices do invite patients in order of clinical risk. So if you've not had an invite, perhaps you're not as at risk, but it still means that some people are waiting too long for their NHS health check. Just to reiterate, the providers I discussed earlier, including 360 Partnership, that they are a federation that manages the majority of our GP practices in Northampton through a subcontracting arrangement. So there is some emphasis on them to support us in managing the GP practices individually. But does that answer your question? Is there anything I've missed out?
It was just the point about all of them actually being in the system, not just the ones.
Yeah. Go on, Councillor Lee.
Thank you. It's just according to our key performance indicators that go to the executive this week. I believe 2% of the eligible population is being invited, and because only 1 in 2 approximately take it up, only 1% are actually getting those tests. So it is a very low proportion. But I take on board everything else, that our GPs are very pressured at the moment. So I'm not blaming anyone for that. But it is a low level, as Councillor Norman says.
Yeah, our the KPIs are measured against a 5-year rolling cycle, aren't they? So although 2% or the 2.1% for Q3 for health checks completed, the target is 3. So obviously that's only 2/3 of our target. So it is absolutely down. I suppose in this context, it's not out of 100%. It's only out of 3%. So it's not as bad as perhaps it might look at first glance. But like I said, I think touched on it earlier. The uptake is one of our key challenges nationally, so continue to try and address it where we can.
Thank you. Councillor Maxwell, please.
What I'd like to say is actually I find it quite interesting. So, for example, my GP practice, which before COVID had 10, 11 doctors, during COVID, 2. These 2 actually operate from Salford. You know, they communicate from Salford to the practice. Hence, that the actual patients, those 11,000 patients attend this practice, right? And I'd have to say that it's not up and running at all properly. And the issue is that the generation of people who should be going, you know, for checkups, right, aren't going. And they're not checking up on the people who actually need it. And I personally feel that we're now, is it 3 years out of COVID, are we? Yeah, right. And quite frankly, you wouldn't even know, you know, what's changed. It worries me. It worries me that they are not meeting the needs of the people, of the population. I think that GPs feel that you can see why more people are going private because they feel they'll get the attention. And I think really that having health checks are great, right? But who you're actually directing it to. And I think people have now become, what is the problem? What is the point of actually contacting a GP? Because one, you won't get an appointment, right? And the only way you're going to get an appointment is actually physically, which is what I did. Turn up 8 o'clock in the morning to get an appointment for antibiotics. I was
Sorry, Councillor Maxwell, I think GP
but can I
appointments
just explain
and availability has come to the
that
next
what
meeting.
happened was...
Keep it to health checks, please.
Can I just explain? As a result, I did get to see a doctor. But what I'm saying is nobody is checking up on these GPs. Nobody is going round to see exactly what's going on. You really don't really see what's going on at the grassroots. And I just feel a lot of patients are missing out. That's my concern at the moment.
Yeah, Jane, please.
Can I mean, what I would say, Councillor Maxwell, with that is that one of the reasons why we want to offer a diversity of options for the health check is that some people don't want to go to the GP, some people are having trouble getting there and various other things. So that's why we want to give a different offer. And places like Northampton Town Football Club have done really well with that. So we want to try and grow that because we need to have a really diverse offer that people feel is accessible. So I hear your comments, and I think, Chair, that primary care access is on the forward plan, I believe, for May, for a discussion, which is very timely considering Councillor Maxwell's response.
Yeah, absolutely. Thank you. Thanks for that, Councillor Maxwell. Councillor Jackson.
Unfortunately, my question was very similar to Councillor Maxwell's because I was about to say the problem with Higham Ferrers, the GP there is consulting everything over the phone. Well, over the years, they must miss quite a few illnesses that they would have spotted had the customer gone into the surgery. But obviously, not a problem.
Again, I think that's within the GP appointments and availability, which will be on the 12th of May, which we can scrutinise those issues there. Do we have any further questions on this point, on this item? No. Thank you very much, Andrew. Thank you, Jane. I think we will. If you can, yeah, we can sort that out. Thank you. Okay, on to the next item, the scrutiny, health scrutiny work plan. So the health scrutiny work plan should be on the done within scrutiny management board. But I mean, Raj, if you can take us through that.
Yeah. So, as is displayed on the screen, the next meeting of health scrutiny is to be held on the 14th of May. Currently, we have 3 substantive items on that agenda. So that includes the Northamptonshire Healthcare NHS Foundation Trust Quality Report, the NHS ICB 5-year joint forward plan, and GP performance and availability. So, yeah, if there are any other topics that we would like the Scrutiny Management Board to consider to come to that meeting, I think we can open that up.
Councillor Lee.
What about children's health checks? Because that's something that became the the responsibility of local authorities in 2015, and combined with that, a vaccination of children as well. That's what I wanted to propose, because I thought that was important. And of course, there is the performance of Kettering General Hospital. The maternity unit is giving cause for concern, but we're already discussing that, I believe, soon at the next meeting. So, yeah, those were the ones. Thank you.
Noted. Thank you, Councillor Lee. Any further contributions anyone want to hear to be scrutinised at the next meetings? I've got down. Well, I believe that the NNC homelessness strategy should be going through the executive. It's not gone through pre-scrutiny already. I'd want to see that at this committee, and also exclusions is something I'm discussing at Scrutiny Management Board as well. I think that'll be a big topic for us to discuss at Scrutiny, as this is health and education scrutiny. Anyone else on points? Councillor Maxwell, please.
Well, I was wondering whether we had for children, the psychology service, what is actually available for them, for mental health. What are we actually doing for mental health for children? The waiting list apparently is really long, and I was wondering whether we could see what is actually being done in that area, actually.
Thank you, Councillor Maxwell. That's been noted. Any other points to this health scrutiny work plan? No. Thank you very much, and that brings us to the close of the meeting. Thank you. Cheers.